Mr. Chairman and members of the committee. My name is Elizabeth Mitchell. I'm the CEO of the Maine Health Management Coalition, and I want to start by thanking you for taking on this issue. As I'm sure you well know, employers and state governments can no longer afford cost increases. Our employees can't go further years without wage increases, and our providers are increasingly burdened in a system that does not reward high performance and creates daily barriers to improving care for patients, largely due to current payment systems and a lack of data. Thank you also for hearing from a Regional Health Improvement Collaborative. We are an employer-led, multi-stakeholder collaborative based in Maine. We've been around for 20 years, and we include employers from the state employees to LL Bean to the Medicaid program, large multi-specialty groups, academic medical centers, and primary care physicians. We work together in a partnership to improve quality and reduce costs. Maine has been very successful in addressing quality. We have some of the best healthcare quality in the country. We know that our efforts in data sharing, measurement, and public reporting have been key to achieving those gains. However, despite these achievements, quality and safety failings continue. And more discouraging is that the quality improvements have not reduced the cost of care for purchasers and patients. Cost and quality vary by region, as do opportunities for improvement. Maine is the birthplace of the Dartmouth Atlas, where Dr. John Wenberg first observed vast differences in maternity care within Maine, with no correlation to demographics, patient acuity, or patient preference. He also noted that his kids would have received vastly different treatment for their tonsillitis if they lived one county away. Variation in cost is even more pronounced. Just as there is no single problem facing healthcare, there is no single one-size-fits-all national solution. I believe with adequate data and support, regions are well positioned to not only identify but help solve their own problems. Data is necessary to identify regional improvement opportunities and to engage stakeholders in improvement. The Dartmouth Atlas would never have been possible without good data. But data is necessary but insufficient. Once opportunities are identified, stakeholders, particularly physicians, must be actively engaged to change current practice. We must now be equally effective using data to engage physicians, purchasers, and patients in care improvement. Data is essential for many, many reasons. Identifying priority cost and quality improvement opportunities, enabling performance measurement and public reporting, establishing cost and quality performance targets, informing choice by consumers, engaging physicians, and managing population health. The premise of medical homes and ACOs is better management of population health, but it is both unreasonable and unfair to ask physicians to assume risk without adequate, timely data. States and communities face different challenges, and physicians need local, timely data to direct their work. To direct physicians to focus improvement efforts on non-priority areas is a sure way to frustrate them when they are not even paid for this improvement work. But they know where care can be improved, if you ask. Significant savings are also possible through readmission reduction, through improved C-section rates. There are opportunities around the country if you have the right data to target them. You rightly recognize the central role of measurement in both improvement and accountability. A key barrier to addressing costs in ways that were equally successful to addressing quality is the lack of nationally endorsed cost measures. Without measures endorsed by the National Quality Forum, we found it impossible to reach consensus on relevant metrics. Regardless of the payment system, appropriate and transparent measurement is required to understand how patients fare in new models. Good outcome and patient experience measures will also support more flexible payment models. New models and incentives to reduce costs must be balanced by ongoing measurement. You reference physician-endorsed measures, but we would urge you to consider multi-stakeholder endorsed measures. As those who pay for and receive care, purchaser and patient voice are crucial to identifying the right performance indicators together with physicians. Whether measurement or population health management, none of this work is possible without data. Unfortunately, multi-payer data is very hard to obtain. Many health plans consider it proprietary. Many provider-run data organizations are reluctant to share it publicly. But as Dr. David Howes, the president of Martins Point Healthcare, summed up our challenge, the age of competing for market share by controlling access to data is over. Transparent, all-payer data should be made widely available, and competition should be based solely on performance. Medicare's Qualified Entity Program is an important step toward giving communities and providers the information they need to improve care. The Qualified Entity Program is a strong signal of partnership and support for local innovation and an endorsement for use of integrated data. CMS should not only continue to enable qualified groups to share data, but you should accelerate it with financial support and greater flexibility. Regional health improvement collaboratives are stewards of multi-payer data and experienced leaders using the data for improvement. We may be your innovation infrastructure and partners for implementation on the ground.
Thank you, Ms. Mitchell.